So I will briefly talk about what are neuroendocrine tumors in the pancreas, and then how we manage some of the pancreatic or peanut tumors, the pancreatic neuroendocrine tumors, with 2 case presentations as well. And then, talk about the role of surgery in metastatic pancreatic neuroendocrine tumors, as well as a trial that we have going on at Vanderbilt currently. So the pancreatic neuroendocrine tumors, or peanuts, account for 3 to 5% of all pancreatic tumors. And luckily for us, they are relatively indolent compared to a pancreatic adenocarcinoma or the garden variety pancreatic cancer. And they account for roughly around 7% of all neuroendocrine tumors. Now, the classification is really important because surgical management depends on the classification as well. So we can classify them if they are, something runs in the family, so a familial pancreatic neuroendocrine tumors, or sporadic, which is there's no family history whatsoever and patients develop these tumors. And then the other way of classifying it is if these tumors produce any hormones, so based on functionality. So the ones which produce hormones, they are called functional pancreatic neuroendocrine tumors. The ones who don't produce hormones, they are called the non-functional neuroendocrine tumors. So 90% of these tumors are actually, there's no family history whatsoever, and they develop it. On the other hand, the familial syndromes account for around 10% of it, in which there's a family history that it runs from generation to generation, and they develop these neuroendocrine tumors, and they are listed right here. The functional tumors are interesting because they produce these hormones, and because of the hormone production, they are diagnosed early, because sometimes, not always, and I will show a case in which, it took a while before, sometimes these patients are diagnosed. And the 2 most common functional tumors are insulinomas, so these tumors produce more insulin levels, and gastrinomas. Gastrin is, results in increased production of acid from the stomach, and they have a lot of ulcers, not only in the stomach, but in the proximal small intestine as well, and they're really symptomatic. And the bottom 3, listed there are fairly rare, but we see it often. And they account for only 10% of all the neuroendocrine tumors. The remaining of the pancreatic neuroendocrine tumors do not produce any hormones, and they are called the non-functional pancreatic neuroendocrine tumors. Now, these, compared to the functional tumors, have worse outcomes because more often than not, they are at a higher grade, and they present later as well because they don't have the symptoms from the hormone production. So they will present with metastases, and some of them, are deemed unresectable at the time of diagnosis. So this is the WHO classification for neuroendocrine tumors, and the same applies to it. And it's important, that some of them, are well behaved. So the grade 1 and 2, they behave well. The grade 3, and then the worst one is the grade 3, or what we call the neuroendocrine carcinoma, not tumors, and those are super aggressive. And those are the ones that should be treated with chemotherapy rather than surgery. So what is the goal for surgeon in management of pancreatic neuroendocrine tumors? So the goal for us is to select the right patient, do the right operation, and minimize, or eliminate any complications, which is hard to do, because anything we do in medicine is associated with, risk. Having said that, if you go to a high-volume institute, like Dr. Boudreau showed his data, the outcomes are better because there's a lot of experience, and it's not just the surgeon, but it's a team effort. It's a team effort that results in better outcomes. And the goal for us is not only to eradicate the tumor, but also get the patient back to their baseline or even better. And this was highlighted eloquently by Dr. Boudreau in his talk, just moments ago. So what about patient selection and optimization? So age, there's no real age cutoff. To be honest with you, I have operated on pancreatic neuroendocrine tumors as young as 13-year-old, and the oldest I have operated on at the age of 92, But those patients, took care of their health, and they have really good performance status, and they did well. And then I have refused some patients who haven't taken care of their life, meaning they have smoked their lungs out and they have, just poor health, and we just didn't feel like, doing a surgery will help them rather than harm them, and we haven't done it, And then, what other illnesses they have, we take that into account. And then when we are, deciding on which patient should undergo pancreatic surgery, we'll refer them to our endocrine clinic and nutrition, ahead of time to help those patients as well as the family members what to expect after the surgery so that they're better prepared to manage their life and quality of life after the surgery. And we do have a high-risk anesthesia clinic. Some patients are sicker, and we refer them so that they are evaluated head to toe so that we know ahead of time, hey, are we going to help these patients? Because the goal is not just to do the surgery. The goal is to do the surgery to help with the cancer, but as well as improve the quality of life. So the surgical management of pancreatic neuroendocrine tumor, surgery is the only form of curative treatment. If we identify it early, we resect it, it can cure the patients. And the decision and the surgical approach on operating on peanuts, depends on the type of the pancreatic neuroendocrine tumor they have, the size of the lesions, the grade, the functionality, and whether they have a history of familial versus incidental diagnosis or no family history diagnosis of pancreatic neuroendocrine tumor. So let's start with the patients with functional pancreatic neuroendocrine tumors. So these are the ones that produce the hormones, and as long as they are resectable, meaning we can get all the tumor out, the goal is to offer them surgery. And the surgery will vary depending on where the tumor is and the size of the tumor. So the pancreas is this structure right here, which is the shape of a fish. The head of the pancreas right here will require us to do a Whipple procedure. It's one of the complicated procedures we do in a human body because you have to cut the pancreas, the bile duct, the gallbladder if it's still there, part of the first portion of the small intestine, and take the lymph nodes around it. And then, we do 3 connections. We have to connect the pancreas back to the small intestine, the bile duct back to the small intestine, because the pancreatic juices helps us digest whatever we eat. And unfortunately, those juices can digest your own tissue because it doesn't differentiate whether it's food inside the intestines or your own. So, Bob was right. Sometimes the normal pancreas is soft as butter, and it's like sewing butter. And then the bile duct needs to be connected, and the stomach needs to be connected with the small intestine. Now, if the tumors are what we call the body and tail of the pancreas, usually we just need to resect that, but there are no connections involved. And the other thing that we sometimes can do on these patients is we can just carve these tumors out. So if it's a really small tumor, 1 or 1.5 centimeters, and it's away from the pancreatic duct, sometimes we can just carve that out and not do a formal pancreatic resection. And the goal is, if we do standard surgery on these patients, is to procure the lymph nodes as well. Bob showed, small intestinal neuroendocrine tumors, they metastasize to the lymph nodes. The pancreas tumors do the same thing. They metastasize to the lymph nodes. So the goal is to at least get 11 to 15 lymph nodes during the resection. What about the non-functional tumors? So it is recommended for any pancreatic neuroendocrine tumor that's non-functional greater than 2 centimeters in size. And the approach is usually to do a formal resection, either a Whipple procedure or distal pancreatectomy, and take all the lymph nodes out. And why is that recommended? Because the 2 centimeter or greater than 2 centimeter tumors, the risk of lymph node metastases increase. So formal resection is indicated in those particular cases. So then the question you need to ask me is, what about the tumors which are less than 2 centimeters? So there are multiple studies done, and actually recently I completed an ASPEN trial as well, which is a multi-institutional international trial. And if you look at these tumors, some of them, which are less than 2 centimeters, whether you do surgery or you just continue to watch them with periodic CT scans or MRIs, there's no difference in survival. And this is a study from a single institutional study of around 500 patients, and they observed these patients for 44 months, so over 3-4 years. And the ones that had less than 2 centimeter tumors, none of them metastasized during the time period. So if the tumor is less than 2 centimeters, it's a viable option not to offer surgery. The ones which are less than 1 centimeter at Vanderbilt, and I think at most big neuroendocrine institutions, we observe them and not offer surgery. 1 to 2 centimeters, it's a gray zone. Majority of the time, we'll observe those tumors, but sometimes we take into, in selected cases, based on the patient's age, surgical risk, growth rate. So if, it was 1 centimeter and we got the next scan and it went up to 1.7 centimeters or 1.8 centimeters, then we will, offer them surgery rather than waiting for it to be greater than 2 centimeters. And some of it depends on the biopsy results, or if the main duct of the pancreas is increased. Those are the high-risk features, and we will recommend surgery even if it's less than 2 centimeters in size. So for the surgical approach, we can do these surgeries open, which will require sometimes big incisions, or we can do it robotically. And we offer at Vanderbilt robotic surgery for pancreatic resections. And the benefits of it is that if we can do the surgery safely and do a good cancer operation, then they have a lower length of stay, lower blood loss, they have a faster recovery, and lower wound infections, and subsequently, incisional hernias. So here's a case of, actually in the past month, a 39-year-old female with 2 young kids who were having symptoms of headache, dizziness, fatigue, confusion, and disorientation. And those symptoms have been going on for 6 years. And, beginning of this year, it prompted her to go to the emergency room, and they found out that, her blood sugars were really low. So she was, sent to an endocrinologist who did the workup, and workup revealed that she has probably insulin-producing tumor. Here's the CT scan, and the CT scan shows this 1.9 centimeters tumor, which was continuously secreting a lot of insulin hormone, and that's why her sugars were really low. We did the copper dotatate scan, and it showed that there was no evidence of metastatic disease, so we did a robotic Whipple on that patient, and she went home in day 4. When we do the Whipple procedures with the bigger incisions, those patients roughly stay around 8 to 10 days, in the hospital. The final pathology revealed that it was a 1.9 centimeter tumor, well differentiated, so it's not one which is misbehaves. All the lymph nodes were negative, and we believe that hopefully this was a curative procedure. And more importantly, she stopped having episodes of low blood sugars, and now she can go play with her kids and not worry about her sugars dropping down when she's driving. So here's another patient that I operated. I think I shared this patient with Dr. Ramirez. He's a 30-year-old, veteran, and was having some abdominal discomfort for 3 months with increasing fatigue. Super active guy, but something was not right. And normal bowel movements, completely healthy, and labs were okay. And finally, the primary care physician, got a CT scan which revealed this big tumor right here, 5 by 4 centimeter tumor in the pancreatic tail. And, there was no any evidence of metastases elsewhere, so we took him and did a robotic distal pancreatectomy and splenectomy. So we took the spleen and the pancreas out. He was actually discharged the next day, less than 24 hours later, because we were able to do it robotically. And it was a, 4.6 centimeter tumor, well differentiated. We were able to robotically get the 16 lymph nodes, the numbers of lymph nodes we wanted, and he doesn't need any further treatment either. We'll just continue to watch him to see how he does, and as long as to make sure that he doesn't recur. So what about the patients with familial neuroendocrine tumors that runs in the family? The issue with these patients is that they will have multiple tumors throughout the pancreas. So usually we drag our feet about operating on these patients because they behave a little bit less aggressively than the others that I mentioned, especially the non-functional tumors. And we try to preserve their parenchyma or the pancreatic tissue so that they don't become diabetic or they don't become insufficient with pancreatic digestive enzymes. So usually we will try to either enucleate or do smaller surgeries rather than taking the whole pancreas out if they have multiple lesions. So what about the metastatic disease? Unfortunately, this is the sad reality. 60% of patients with pancreatic neuroendocrine tumors, especially the non-functional ones, will present with liver metastases, and Dr. Boudreau alluded to the fact that most patients with the progression of disease in the liver will the liver will fail, and that will take their life. So there is data that you can debulk these tumors, and Dr. Boudreau highlighted a case of that young patient in which he was able to take all the disease out of her liver, and she was disease-free 3 or 5 years, later. So there's definitely a role for cytoreductive surgery to reset the clock, but the decision needs to be made in a multidisciplinary, tumor board fashion as a team decision that, hey, what's the best route to go? Because there are multiple, treatment options that, we can offer these patients. So Dr. Boudreau talked about the histotripsy. I will show you some cool videos. So these are the ultrasound, waves that are going in, and what it does is creates these micro bubbles that, starts to oscillate or, moves, and what it does, is completely liquefies the tumors, as Dr. Boudreau was mentioning. And you can really use ultrasound guidance to target these lesions, and, it has to be under general anesthesia so that the patients are not moving. And so, how does it look, and Dr. Boudreau mentioned that it forms this sphere. So here's a cow liver in a formalin block. And as Dr. Boudreau mentioned, it forms a sphere, and the tumor is highlighted by the green dots, so you can get a good margin. And how does it look? So here's an example. The same block that we, use the histotripsy on it, and this is how the cow liver looks after. So, and what Dr. Boudreau mentioned about abscopal effect, it does something to the immune system, and we don't know how, But the other lesions that are not treated with this, so we can treat up to 3 to 5 lesions, and it's repeatable, but it does activate the immune system. Now, here's the ultrasound, and the black is the tumor, and see how it liquefies it, and in real time, you can see the results. And the best part about it, it doesn't affect the normal tissue. So unlike microwave ablation or surgery and stuff, we have to resect it. With the microwave ablation and stuff, you can injure the bile ducts or, the blood vessels and stuff. It doesn't affect the key structures that we want to protect and save the patients. So the benefit of it is we don't, we preserve the liver tissue. It doesn't hurt the veins or the bile ducts. You can see the radiographic results. Completely non-invasive, no poking of needles, no incisions, immediate results, and it's repeatable. And the patients go home the same day. Good news is, people who live in Tennessee and neighboring states, they don't have to go to visit Dr. Boudreau. We'll have this machine in November and December, of this year. Now, I'm going to change gears and just, highlight a trial that we have. So we know, we can achieve cytoreductive or debulking of these tumors in the liver up to 70% or so, but we cannot remove all the tumors. Now, we know from the PRT data that it doesn't work really well on tumors that are greater than 3 centimeters in size. So then we thought, why can't we just combine the two of them and debulk these tumors in the liver that are greater than 3 centimeters in size, and then do the PRT. And we are currently enrolling 6 patients. It's a small study as a proof of concept that I'm partnering with Dr. Ramirez and our nuclear medicine folks, to enroll patients in it. So with that, we'll take any questions or, but that's the end of my talk.